morning, everyone. I'm going to present the first case of a student CPC. My patient is Master D, 16-year-old male student from Roopnagar, Punjab. From treating unit was Gastro 1. Date of admission was 6th of July 2017. Date of death was 10th July 2017. Duration of hospital stay was 5 days. Patient got admitted with the complaint of high-grade fever. Maximum documented is 103 degree Fahrenheit for 1 month duration. A dry cough for 1 month. Shortness of breath for 3 weeks. It was progressive from MRC1 to MRC4. Streaky hemoptysis for 1 week duration. It was associated with on and off scanty nasal bleed and nasal obstruction for 1 week. And there was associated loss of appetite and loss of weight. There were no history of chest pain, palpitation, orthopnea or PND, no history of abdominal distension or jaundice, no history of pronounced or skin rashes, oral ulcer, joints pain, alopecia or Zika symptoms, no history of decreased urine output or hematuria. Past history, family history and personal history were not significant. There was no history of diabetes in the family. On examination, patient was drowsy, there was tachycardia was there, BP was normal, and there was swelling over the nose. It was growth in the left nasal cavity, no active bleed was there. On systemic examination, respiratory systems, chest expansion was decreased in right side with decreased breath sound in the right infraclavicular, mammary and axillary area and left axillary area. Bilateral captations were present. Rest of systemic examination was normal. Investigation, the pre-admission before getting admitted in the PGI in June 2017. Sputum FB was positive from outside. HIV was negative. CCT chest shows the multiple confluent area of mass-like consolidation in bilateral lungs. Few of them giving the air bronchogram sign with surrounding GGOs and area of breakdowns within cavities. Multiple large discrete nodules lesions are seen scattered in both lungs. No lymphadenopathy of pleural effusion was seen. Later they did the CT-guided FNAC that shows the KOH positive fungal colonies, even though they have not mentioned anything about the morphology of the fungus. No atypical cells or granuloma was seen. ZN stain was negative 5FB. Gram stain showed the gram-negative cocci. Other investigation, hemogram, hemoglobin was, there was decrease in the HB level after getting admitted in the PGI, maybe most probably due to the nasal bleed or hemoptysis. Rest was normal. Biochemistry, there was a slight derangement of LFT. OTPT was 55 and 1 not 10. That was after starting the ATT. ATT was started on 12th and this is on 20th value. And total bilirubin was 1.76. ABG was initially normal, and in the terminal event there was a metabolic acidosis, that's lactic acidosis was there. In PGI, he was investigation, infective workup was normal, procal was increased 7.81, HbA1c was 6.5, the vitamin D3 was 8.65, and there's an ANCA negative, and USG whole abdomen shows the hepatomegaly. ECG was normal except the sinus tachycardia was there. Course, pre-admission before getting admitted in the PGI, symptomatic since 4th June 2017, that is the day 1 of the illness, with high-grade intermittent fever, dry cough. For that X-ray was done, that shows bilateral infiltrates. Sputum FB was positive. In view of that, they have started ATT on 12th of June, that is day 8. But there was no improvement in the symptoms, and day 24, patient, there was a slight derangement of the LFT. In view of that, they have stopped the ATT from outside. Later, in view of worsening symptoms, CCT chest was done, which shows the multiple consolidations with air bronchogram sign and the cavity in bilateral lungs, with discrete nodules were there in bilateral lungs. And later they did the CT-guided FNAC, which shows the KOH smear positive fungal colonies and the gram-negative cocci. In PGI, he got admitted after 1 month of the illness, presenting with high-grade fever, dry cough, shortness of breath, on and off scanty nasal bleed and nasal blockage, and hemoptysis. He started again in view of KOH positive fungal growth. He was started at amphotericin B, and ATT was restarted as the LFT was normal at that time, and IV antibiotic peptaz was started. But patient didn't show any sign of improvement and continued to be worsening in the form of increased oxygen requirement. Later, ENT consultation was also done in view of scanty nasal bleed and nasal blockage. On examination, it showed the clot is in the left cavity and hypertrophic turbinate, and they advised for the oxymetazoline nasal drop. No biopsy was done. But we did the autoimmune workup also. ANCA was negative. HbA1c was 6.5%. Throughout the admission, RBC value was 86 to 212. we have only single value of HbA1c. Patient continued to worsen, FiO2 requirement increased. Later, it was planned for the lung biopsy on 10th of July, but in morning of 10th July, day 36 of the illness, he developed increase in FiO2 requirement. Patient got admitted, and later he developed a cardiac arrest. CPR was done as per SCLS protocol, but could not revive, and declared dead at 9 a.m. Discussion of basic disease, ATT-induced hepatitis, pre-terminal events, and final diagnosis. Database, we have the persistent high-grade fever, dry cough, shortness of breath, scanty hemoptysis with on and off nasal blockage, and loss of weight and loss of appetite. Microbiology, sputum was positive, and X-ray showed bilateral infiltrate. CT chest was bilateral consolidation with GGOs and multiple nodules with cavities. And FNAC-guided KOH positive fungal colony was seen, and gram-negative cocci. Procal was 7.8, and HbA1c was 6.5, and with hepatomegaly. So, syndromic diagnosis, we have kept necrotizing pneumonia with lung abscess, necrotizing pneumonia about lung abscess, prolonged high-grade fever, hemoptysis, constitutional symptoms were there, and the CT chest picture shows the consolidation with cavitations. But we don't have any radiological imaging. It is not available. Etiological differential diagnosis, first we have kept the pulmonary TB. For that, in constitutional symptoms were there, hemoptysis, sputum AFB positive, CT picture, even though it was not classical, but TB can present in any form. Against was the no response to ATT and the rather progression of disease. Biopsy AFB negative, but fungal was positive, so it's a probable diagnosis. Second was the invasive pulmonary aspergillosis. The constitutional symptoms, hemoptysis, bilateral nodules with cavities and GGOs. Lung FNAC shows the fungal colonies, even though they have not described the fungal morphology in this case. And HbA1c was 6.5. Corresponding HB was 8 gram per deciliter. Against was the no prior history of the immunocompromised state. Lab do not show suggestive of any neutropenia. So likely diagnosis. Can it be TB plus IPA co-infection? There is an article in European journals. It was published. It's concomitant pulmonary tuberculosis and invasive pulmonary aspergillosis infection in immunocompetent host. This shows that even though it is very uncommon for TB and invasive aspergillosis in healthy individual, but this they have described a case where the healthy young adults without previous structural lung damage were presented with TB with invasive aspergillosis. Fungal co-infection with TB describe the Aspergillus niger, fumigatus, and the histoplasma infection can be there, or cryptococcosis. This was that index case they have described in their article. This was the first X-ray which was done, which shows the left-sided consolidation, patchy consolidation. After 2 weeks, they repeat the X-ray, and there was the pneumonic consolidation in the left upper lobe with air fluid level. Corresponding CT shows the air fluid level with necrotizing pneumonia with early lung abscess. Third one, we have kept a nocardia. That is possible. Constitutional symptoms, hemoptysis, CT picture, nodules, and cavity. AFB positive, even though it's sometimes the weaker SCL used for de-staining that lead to the weak acid positive AFB. And there was no response to ATT in AMPO. So no, but against point is no prior history of immunocompromised state. Biopsy shows the fungal positive. There's an article which shows that not everything acid-fast is Mycobacterium tuberculosis. This is the pleural biopsy showing the scanty acid-fast bacilli, which later turned out to be nocardia. And there's a possibility of bacterial pneumonia also. That's fever, underlying lung damage, lung FNAC, gram-negative cocci was there. Against was the FB positive biopsy, so fungal positive, and there was no response to IV antibiotics. This could be due to post-bacterial infection. We have also kept a small vessel vasculitis GPA. Far is the constitutional symptom, hemoptysis, nasal bleed and discharge. CT picture showed bilateral nodules and cavity. No response to IV antibiotics, antifungals, and anti-tubercular drugs. Against was the ANCA was negative, sputum AFB was positive, and NAC fungal positive. Urine RME was normal in this case. That's a less likely possibility. There could be a possible underlying immunodeficiency. In this case, the primary immunodeficiency, secondary diabetes mellitus would be possible in this case, even though we have HbA1c only 6.5 and was single value, and FBS PPBOs was not available. HIV was negative in this case, and there could be a chronic granulomatous disease. and the Mendelian susceptibility to microbacterial disease spectrum disorder, interferon gamma receptor deficiency, interleukin 12 or 12 receptor deficiency could be. This is they have shown the acquired and inherited condition with mycobacterial susceptibility to BCG, non-tubercular mycobacterium tuberculosis. There's different etiology they have shown here in this article. There could be ATT-induced hepatitis. Diagnosis of ATT-induced hepatitis, if clinical symptom is present, AST or ALT more than 3 times a baseline or upper limit of normal, and jaundice, bilirubin more than the 2 times the upper limit of normal. If there is no clinical symptom present, AST, ALT more than 5 times the baseline, upper limit of normal. But in our case, it's not fit in the ATT-induced hepatitis, even though they have stopped ATT after 2 weeks. Mortality is in ATT-induced DILI is 22.7%, and ATT-induced ALF was 69 to 70%. So pre-terminal events may be underlying immunocompromised state that lead to pneumonia, other tubercular or IAP, or other cause, no response to treatment or partially treated, progressive worsening of symptoms led to sepsis and type 1 respiratory failure and respiratory shock, and that lead to the final events. The unit final diagnosis, necrotizing pneumonia or lung abscess, etiology but either tubercular or IPA or co-infection, and superimposed bacterial infection, diabetes mellitus, type 1 respiratory failure, and sepsis. Cause of death is type 1 respiratory failure with septic shock. Thank you.
Good morning. I will be presenting the pathological findings for this particular case. So we had a young 16 years old whose autopsy was done on 10th of July 2017. He was diagnosed with septic shock, ARDS, fungal pneumonia, and sputum-positive pulmonary tuberculosis. We did a partial autopsy, and all the serous cavities were within normal limits. Our main organ of interest, the lungs, they weighed around approximately about 2,200 grams. Grossly, we can see there is pleural abnormality, and we see multiple nodules ranging from 2 to 3 centimeters in size. These nodules are coalescing at areas. These nodules are coalescing at areas and forming consolidation. The pleural aspect of the lung is dull and shows thickening with areas of fibrinous tags. In the posterior surface, we see the same nodules and geographical areas of consolidation, but we can appreciate the tracheobronchial tree is normal and does not show any lesion or ulceration. Now coming to the cut surface of the lung, the cut surface of the lung shows multiple abscesses ranging from 1 centimeter to 2.5 centimeters in size with central areas of breakdown and necrosis. These nodules again are coalescing to form confluent areas of pneumonic consolidation as been shown, and intervening areas of the lung parenchyma are discolored and hemorrhagic. These are the microscopic sections from the tracheobronchial tree which show superficial mild chronic inflammation. These are the microscopic sections from the pleura which show fibrinous pleuritis. Various representative areas from the lung were taken and evaluated, which show these diffuse bluish areas comprising of neutrophils intervening with pale areas of fibrosis. We can also appreciate that the bronchus has been involved by these areas of necrosis. This is the bronchus, and these are the areas of necrosis. On further magnification, we can appreciate that these areas of necrosis are comprising of numerous neutrophils and karyorectic debris, along with foreign body type of giant cells and fibrosis. Now the vessels adjacent to these areas of necrosis show transmural inflammation along with fibrinoid necrosis and intraluminal thrombi. This is the thrombi. And on performing the Marshall scarlet blue staining, we can appreciate this fibrinous thrombi is further confirmed. So the normal elastic tissue on elastic von Giesen stain is appreciated to be black, but however here we can see that the elastic lamina is not taking the staining, suggestive of secondary vasculitis. PS stain for fungus, zeal-nescence for acid-fast bacilli, modified zeal-nescence for nocardia, and Grocots for fungus was performed, and all were negative. These special stains were performed on multiple sections and in different settings, and all yielded negative results. So we've taken, on microscopic evaluation from the adjacent lung parenchyma, we see diffuse alveolar exudates along with hemorrhage and hyaline membrane formation. This is a higher magnification view where we can appreciate the hyaline membrane. And this hyaline membrane appears bright pink on the PS stain. PCR for TB, both typical, atypical, for fungus and for bacteria, we had negative results, courtesy Department of Microbiology and Mycology. Multiple sections from the hilar lymph nodes were examined and reactive lymphoid hyperplasia was noted. Now coming to the organ complex. This organ complex comprises of a slice from the liver, the gallbladder, C-loop of duodenum, pancreas, and a slice from the spleen. The liver weighs around 1400 grams, and grossly, the outer surface did not show any abnormality. The cut surface was smooth and did not show any focal lesion nodularity. However, when we come to the spleen did show subcapsular thickening. Along with these tiny whitish nodules in the parenchyma, we can also appreciate an infarct measuring 1.222 centimeters in size. Coming to microscopy of the liver showed normal architecture, which was further confirmed on the reticulin stain. On performing Mason's trichrome, we did not find any evidence of fibrosis. When sections from the infarcted area of the spleen were examined, we saw pale areas of infarction rimmed by neutrophils, confirming the presence of an infarct. These are microscopic pictures from the nodules, the tiny nodules from the spleen, which show suppurative granulomas comprising of neutrophils and histiocytes. PS stain for fungus, zeal-nescence for acid-fast bacilli, both were negative. The adjacent vessels from the spleen showed transmural inflammatory infiltrate and fibrinoid necrosis, suggestive of secondary vasculitis. This is a microscopic picture from the pancreas, which did not show any diagnostic pathology. The organ complex comprising of both the kidneys measuring 9.5 into 3 centimeters along with the abdominal aorta, the ureters and the urinary bladder were normal. The outer surface of the kidney, the capsular surface was smooth and the cut surface showed distinct corticomedullary junction. On microscopic evaluation of the kidney, the glomerulus and interstitium did not show any abnormality. However, when we come to the tubules, we do see shedding of the epithelial lining along with simplification, suggestive of acute tubular injury. This was further, the glomerulus had normal pathology on PS staining, and on performing Mason's trichrome, we did not find any evidence of fibrosis or crescents or necrosis or proliferation in the kidney. The capillaries of the kidney did not show any evidence of vasculitis and were of normal morphology. These are the sections from the adrenal, and they did not show any diagnostic pathology. The periadrenal arterioles showed normal morphology, and they do not show any evidence of secondary vasculitis. Now coming to the esophagus and the stomach, Grossly, they did not show any abnormality. However, on microscopy, we found chronic superficial gastritis. The small intestine grossly did show diffuse discoloration superficially, but on which was further confirmed on microscopy as mucosal ischemia. The colon did not show any abnormality grossly, but on microscopy we did find submucous fibrosis. Now coming to the heart did weigh 220 grams. The outer surface is normal. On cutting open, all the chambers and the valves from the right inflow, the right outflow, the left inflow and the left outflow were normal and no vegetations were noted. Normal histology of the heart was confirmed. Microscopic evaluation of the testes, mesenteric lymph nodes, skin, and the skeletal muscle did not show any diagnostic pathology. In a 16-year-old with septic shock, acute respiratory distress syndrome, fungal pneumonia, sputum pulmonary tuberculosis, and ANCA status negative, a final autopsy diagnosis is necrotizing granulomatous inflammation with secondary vasculitis and diffuse alveolar damage, suppurative granulomas in the spleen, kidneys with splenic infarcts, acute tubular injury. Keeping in view the following findings, necrotizing suppurative granulomas in the lungs and the spleen, suppurative granulomas in the kidney, histochemistry for acid-fast bacilli, nocardia, fungi, and bacteria, all negative, PCR for tuberculosis, both typical and atypical, fungus and bacteria negative. A possibility of granulomatosis with polyangiitis needs to be considered. Correlation with ANCA levels is required.
The case is open for discussion. Ma'am, please.
Good morning. In a setting of PCR negative, TB still cannot be ruled out because patient is 16-year-old male. However, I agree with Dr. Itambra that GPA needs to be excluded here. Maybe isolated lung involvement, kidney is normal. We should have gone for RT-PCR or fluorescent-based techniques to demonstrate AFB. Because patient has received ATT, probably we may not get the AFB even after that. So RT-PCR is much more sensitivity, especially in AFB negative situations, than only the PCR. That could have been performed. Even later you can do it.
Ma'am, please.
So I think we tried our level best to rule out the bugs. I just wanted to show one picture which she missed. So there was one focus out of multiple sections taken from kidney which had this kind of a suppurative lesion. So we, RT-PCR gene expert for TB were done by Dr. Sethi, and he says they are negative. Other PCRs again are negative. So after having excluded bugs, so many sections stained with histochemistry, after that I thought with vasculitis being then, we've been classically teaching if spleen, kidney and lungs are involved, we should consider GPA. And here, since we have ruled out most of the organisms, and vasculitis is present in spleen also, because otherwise it was sounding very difficult, because if hematogenous spread of tuberculosis occurs, it goes to spleen and liver both generally. We don't get isolated splenic tuberculosis. So keeping everything in mind, we thought still though, and most of these investigations, including ANCAs, were done outside, isn't it? Here also? Okay. Okay. Because rest of the investigations all were from outside. That I tried to take out slides of fungus or TB, but then it was told that those FNAs were done outside. So we couldn't confirm those fungal colonies which were reported somewhere.
We'll move on to the next case. Dr.
Good morning, everyone. I'll be presenting the clinical part of today's second CPC. So, We have Mrs. N, a 32-year-old female from Chandigarh, who was admitted in our EM OPD on the night of 19 June 2022, and the date of her demise was 22nd June 2022 in female medical ward. Coming to the background history, in 2017 September, she had a full-term normal vaginal delivery needing PRBC and RDP support. Her first visit to PGI was in May 2018, where she came with an unplanned pregnancy with a period of gestation of 13 weeks, 3 days, with pancytopenia, with an HB of 3.3, an ANC of 760, and a platelet count of 7,000. Her bone marrow, which was done outside, was suggestive of hypoplastic marrow, and the same was confirmed at PGI. So a diagnosis of severe aplastic anemia was made, medical termination of pregnancy was done under transfusion support, and cyclosporin A was started. However, within the next 30 days, she again presented with bleeding PV. She received 3 units of PRBC and danazol was added along with cyclosporin, and then she was discharged. She was under CHMO follow-up after that. Her chromosomal breakage studies were negative and minor PNH clone was positive. So a diagnosis of acquired aplastic anemia was kept. And she was given the option of stem cell transplant versus antithymocyte globulin, but she decided to proceed ahead with cyclosporin. During this period, her platelet counts hovered between 20,000 to 40,000 and reached a low of around 5,000 during her current admission. Her ANC always stayed between 500 to 1,000 and reached a nadir of 0 in her current admission. And her hemoglobin used to stay between 5 to 8 with transfusion support. However, after January of 2020, it stayed between 7 to 8 without any component support, but it reached a low of 4.2 in her current admission. Her last BT blood transfusion documented was in January 2020, and her current admission was in June 2022. So using this table, we can say that for the first 2 years of her treatment, she had no response as she was transfusion dependent. However, after 2 years, she became partially responsive as she became transfusion independent. Now, with this background history, we have a 35-year-old female presenting with a 5-day history of high-grade fever associated with chills, loose stools, 6 to 7 episodes per day, watery consistency with small volume, and pain abdomen, but not associated with blood, mucus, or abdominal distension. Other localizing symptoms were absent, other than a 2-day history of non-productive cough, but not associated with shortness of breath, chest pain, postural or diurnal variation. Past history, family history, and personal history were not significant. Examination was remarkable for tachycardia of 108 per minute and tachypnea. Severe pallor was present. However, there were no signs of any bleed. Systemic examination showed crepes over right infraaxillary area and diffuse abdominal tenderness. So during her short stay at PGI, she had severe anemia with a baseline HB of 4.2, which increased to 6.6 with 2 units PRBC. ANC at presentation was 122, which reached up to 0 on the day of her demise. She developed AKI on the 3rd day of her admission, and OTPT ran into thousands with OT more than PT on the 3rd day. She also had hypoalbuminemia. She had hyperkalemia and direct hyperbilirubinemia towards the end of her stay here. We do not have any reports for the sepsis workup, neither do we have any imaging reports available for her. So with these limited findings, we come to the course and management of the patient. So on 19 June, she presented to EMOPD with fever, loose stools, and pancytopenia. Keeping in view febrile neutropenia, she was started on cefoperazone, sulbactam, and metronidazole. On the night of 20th June, she was shifted to female medical ward, and antibiotics were hiked up to vancomycin and meropenem. The next day, she developed AKI and transaminitis. She received 2 units of blood transfusion, but on the same night at 10:30 p.m., she developed shortness of breath requiring oxygen supplementation. At this point of time, vitals documented were tachycardia of 104 per minute, respiratory rate of 26 per minute, and a saturation of 89% under room air. Examination showed bilateral diffuse coarse crepes and a right infraclavicular wheeze, and an X-ray done at that point showed right middle zone opacity. The next day in the morning, she had to be intubated in view of progressive respiratory distress. She developed hypotension, which was fluid unresponsive, and had to be started on dual inotropes. However, she was afebrile throughout the day. An ABG done at this point showed severe acidosis, metabolic plus respiratory with a lactic acid of 7.57. A repeat X-ray showed right upper and middle zone consolidation, and she was hypoxic even with an FiO2 of 100%. A DNR was requested by the patient attendants, and she succumbed to cardiac arrest on the night of 22nd June. So with these limited information available, we can now proceed to discussion, which will consist of the basic etiology, the extent of organ involvement, and the terminal events and final diagnosis. So now we have a 32-year-old female who presents to us with pancytopenia and hypocellular marrow. These are the broad differentials for such a condition, and the last three are quite rare. So the first three causes, that is acquired versus constitutional aplastic anemia and hypocellular myelodysplastic syndrome, remain high on the cards. Now, all three of them can present with a hypocellular marrow, but the points which favor an acquired cause of aplastic anemia are the age of presentation, minor PNH clone being positive, which is almost always indicative of an acquired cause, and chromosomal breakage studies being negative. The same points also go against constitutional aplastic anemia and hypocellular MDS. However, we do not have the cytogenetics or NGS panel available with us, which would have effectively excluded hypocellular MDS and constitutional aplastic anemia for us. So now we go ahead with a basic disease of acquired aplastic anemia. The severity can be graded according to this, and we can see that she initially presented with a severe aplastic anemia, which progressed to very severe in her current admission. Now, she was diagnosed with aplastic anemia during her pregnancy. So was it a mere coincidence, or is there actually any association between pregnancy and aplastic anemia? So there is indeed an entity called pregnancy-associated aplastic anemia, the criteria for which has been proposed by Snyder and colleagues, and our patient fulfilled all these four criteria that are needed for the diagnosis. The basic cause for this is not known, but it is thought to be due to an imbalance between erythropoietin and placental lactogen. So now we have a patient with very severe acquired aplastic anemia, likely pregnancy-associated. Moving on to the organ involvement in the current presentation, the major organs involved were the GIT and liver, the lungs, and the kidneys. Coming to GIT, we have two broad differentials of neutropenic enterocolitis and a viral gastroenteritis. The points favoring neutropenic enterocolitis are she had neutropenia, fever, pain abdomen, and diarrhea. But the imaging finding of more than 4 mm thickening in any segment of bowel wall for at least 3 centimeters that would have clinched the diagnosis is not there with us. However, we can still be confident that she had neutropenic enterocolitis, and the etiology of which can be bacterial or fungal. So studies have shown that the epidemiology of neutropenic enterocolitis is mostly polymicrobial, consisting of gram-negative bacilli like Pseudomonas E. coli or Klebsiella, gram-positive cocci like Viridin's group of streptococci, and anaerobes like Bacteroides and Clostridium, much more than a fungal cause, which is mostly Candida. However, we cannot rule out a viral etiology, that is CMV colitis, because the points favoring it are an immunocompromised state, diarrhea, pain abdomen, and simultaneous involvement of lungs and liver, which can happen in CMV. However, the points against it are there is no lymph node involvement, and we do not have any supportive stool examination or any endoscopic evidence. So, keeping in view the available information, we'll keep neutropenic enterocolitis as the first possibility. Coming to organ involvement, that is lungs, she developed in-hospital respiratory distress. So we can have a broad differential of pneumonia in an immunocompromised host, transfusion-associated circulatory overload, and transfusion-related acute lung injury. The points which favor pneumonia are she was an immunocompromised host, she had fever, cough, and a unilateral involvement of lungs on chest X-ray. Now, with a patient who has an absolute neutrophil count of 0, we can have all three of these etiologies, fungal, bacterial, or viral. The points which favor a viral etiology are, as already mentioned, a simultaneous GI and liver involvement. And one point against bacterial pneumonia is that she was afebrile on the last day of her illness, and in spite of worsening organ failures, and antibiotics did not help her in improving any organ dysfunction. This is a chart which shows the etiology of lower respiratory tract infections in patients with dysfunction in various components of the immune system. So while we can see that bacteria and virus can infect all of them, patients with neutropenia, like our patient here, do have a propensity for getting infected with fungi. So even though lower respiratory tract infection remains a high possibility, we still cannot rule out TACO or TRALI because the points favoring them are an acute in-hospital onset and a temporal correlation with 2-unit PRBC transfusion. But the points that go against both of them are the fact that chest X-ray showed unilateral involvement, and the point that goes against TRALI is the fact that she was transfused with packed RBCs and she did not receive FFP, and TRALI is known to be caused mostly by plasma-containing products. So for the lungs, we can be sure, we can be certain that she had a lower respiratory tract infection with a fungal or viral etiology more than a bacterial etiology. Coming to liver, at first go, an OTPT of thousands in a patient with sepsis and shock looks like ischemic hepatitis. But if we look at the temporal correlation, she developed hepatitis on the 3rd day of her admission, while the hypotension has been documented on the 4th day. So this effectively rules out ischemic hepatitis. We are now left with CMV hepatitis and a fungal infection. For CMV, there's a simultaneous lung and GI involvement, and fungal infection cannot be ruled out without any imaging or ALP values suggesting infiltration. Renal involvement is most likely septic more than prerenal. Points in favor of points which are against prerenal are she developed AKI prior to developing hypotension, and her blood urea nitrogen and creatinine ratio is less than 20:1. However, it can also be drug induced because she did receive vancomycin and developed AKI after that. So the terminal events can be, we have a patient with pancytopenia having fever, loose stools and shortness of breath. She had pneumonia leading to a type 1 respiratory failure. She had sepsis with refractory septic shock and AKI with hyperkalemia, which might have worsened pre-terminally leading to an arrhythmia. And my final diagnosis will be very severe acquired aplastic anemia, which is likely pregnancy associated with febrile neutropenia, with viral versus fungal versus a polymicrobial pneumonia, with neutropenic enterocolitis, query CMV hepatitis, with acute kidney injury, septic ATN versus drug induced. And the cause of death is most likely refractory septic shock plus a type 1 respiratory failure. Thank you.
Good morning. I'll be discussing the pathology findings for this case. We performed a partial autopsy on this 32-year-old female with 3 days of hospital stay with a clinical diagnosis which has already been discussed. The patient had a thin build and the serous cavities were within normal limits. This is a antemortem bone marrow aspirate which is particulate but hypocellular for age, which is confirmed on this antemortem biopsy, which predominantly shows fat and bony tuberculae with some preserved hematopoietic elements. And similar picture can be seen on this post-mortem bone marrow section. At a higher magnification, it shows depletion of all the 3 hematopoietic elements. Coming to the lungs, grossly the lungs were heavy and weighed in at 1250 grams. Anteriorly, the pleural surface was shiny, no focal lesion or hemorrhages were identified on the pleural surface. Lungs examined from the posterior aspect shows these areas of discoloration as well as these fibrinous tags. The cut section of the lungs shows extensive hemorrhagic consolidation in the middle and the lower lobes with some sparing in the apical regions. These are the hemorrhagic consolidations and these are the relatively spared areas. And these areas were solid to feel. We took multiple sections from the lung and they show extensive alveolar hemorrhage with loss of structural details with relatively preserved lung architecture in the periphery, as these are the hemorrhages and these are the relatively preserved areas of the lung. These hemorrhagic areas were not because of capillaritis, as the alveolar capillary walls did not show any reaction. However, there are these numerous small blue dots which are these extensive bacterial colonization inside the alveoli. Occasional septae also showed thrombi in the vessels. These were, on closer examination, these were composed of bacterial colonies indicating a septic thrombus. The non-hemorrhagic areas were also seen and they showed bacterial colonies, and these had a paucity of inflammation, probably due to pancytopenia. We performed several special stains on the lung sections. This is the gram stain shown here, and it shows the blue gram-positive cocci in the alveolar spaces. However, PAS and gram TOTs performed ruled out any presence of fungi or gram-negative organism. Summarizing the findings in lung: massive pulmonary alveolar hemorrhages, pulmonary thrombi, and gram-positive bacterial pneumonia. This is an organ complex comprising of both the kidneys, ureters, bladder, and aorta opened up posteriorly. The kidneys weighed 220 grams and measured approximately 10 into 3 into 3 centimeters. The capsular aspect of the right kidney shows this suppurative subcapsular suppurative abscess with central areas of necrosis. On the cut surface also we can appreciate these abscesses with central areas of necrosis measuring approximately 0.8 to 2 centimeters. However, the renal pelvis seen here is smooth and shiny, indicating that the abscesses were of hematogenous origin and ruled out the possibility of an ascending infection. The cortex is of normal thickness and the corticomedullary junction is well maintained. We took sections from the abscesses which show central areas of suppurative inflammation bordered by relatively fibrotic walls. One of the artery here in this microphotograph also shows fibrotic occlusion, and these are the areas of this abscesses. This microphotograph shows small intraparenchymal abscesses as seen here in the middle. This is the higher magnification which shows large areas of necrosis, few neutrophils. However, we could not identify any organism. We also performed some special stains which were negative and did not yield any organism. The adjacent renal parenchyma shows age-related scarring. We performed a PS on the adjacent section which shows a normal morphology of the glomerulus along with areas of simplification of tubular lining and epithelial shedding, which is suggestive of mild acute tubular injury. We also performed this MSB stain to show these normal looking glomeruli with fibrin thrombi inside them. So the findings in kidney were multiple renal abscesses with mild acute tubular injury, microthrombi in the glomerular capillaries. This is the organ complex comprising of slice of liver, pancreas, C loop of duodenum, gallbladder and spleen, and a small spleneculi. The liver was normal in size. However, on gross examination, the liver had a brownish discoloration, as we can compare it from a normal liver at autopsy, which is almost tan yellow in color. However, this liver was dark brown. The cut surface of the liver, however, did not show any nodularity or lesion. The sections from the liver show large areas of centrizonal necrosis, as we can see here, with only preservation of periportal hepatocytes. In this higher magnification, there are areas of necrosis around the central vein with the preservation of periportal architecture. We performed a reticulin stain and it shows a loss of reticulin in these areas of necrosis around the central vein. Here it is, here the reticulin stain is a bit preserved. However, we can see this loss of reticulin around the central vein. Messon's trichrome did not reveal any fibrosis, which normally appears blue in this stain. On a closer examination, we could see that there's a coarse brown pigment in the hepatocytes and the sinusoidal Kupffer cells. This type of pigmentation was also present in the portal tract. This pigment was confirmed to be iron on pearl stain, which gives it a Prussian blue color, indicating hemosiderosis. The spleen and the pancreas were microscopically unremarkable. So the findings in liver are centrizonal hepatic necrosis with hemosiderosis. Coming to the GI tract, most of the GI tract was grossly unremarkable. However, certain segments from large intestine in the colon, especially in the IC region and junction, show ulcers with a velvety base and tiny patches of pseudomembrane formation. We can see on a closer inspection this grey pseudomembrane formation on the IC junction, as well as these velvety based ulcers on the large intestine mucosa. Microscopy confirmed the fibrinopulent membrane formation over the ulcerated mucosa. This is the pseudomembrane and this is all the granulomatous reaction with some preserved colony glands. The inflammation, this inflammation had destroyed both the mucosa and the muscularis layer of the affected segment. At a higher magnification, some areas show preserved colonic glands, as we can see here, and the ulceration formed by fibrin and necrosis along with the pseudomembrane seen above. The rest of the preserved mucosa showed denuded lining epithelium, this one, along with microthrombi within the submucosal capillaries. These are the microthrombi within the submucosal capillaries. The Gram torts performed highlighted these red-colored bacilli, their colonies, indicating a gram-negative bacillary infestation. This membrane and ulcer were subjected to gram stain, PAS and ZN, which did not yield any organism. Sections from the small intestine show hemorrhagic discoloration showing mucosal ischemia. Sections from the stomach were grossly normal, showing chronic gastritis by microscopy. The heart weighed 180 grams, which was normal for the age. The external surface of the heart is unremarkable. The right, left inflow-outflow tracts were normal, and all chambers and valves were normal. The microscopy of the heart does not show any significant pathology. Thyroid, skeletal muscle, skin, and the urinary bladder were examined by microscopy and did not reveal any diagnostic abnormality. The uterus and ovary were normal microscopically, and the adrenal also did not show any significant pathology. So my final autopsy diagnosis in a 32-year-old female with a clinical presentation of aplastic anemia, febrile neutropenia, community-acquired pneumonia, acute gastroenteritis and septic shock and acute kidney injury is diffuse alveolar hemorrhages with gram-positive bacterial pneumonia, multiple renal abscesses with mild acute tubular injury, centrizonal hepatic necrosis with hemosiderosis, bacterial colonic ulcers due to gram-negative bacilli, and microthrombi in kidney, lungs and colon secondary to DIC. Thank you.